Yeah. Thanks to the conference people of breast virtual cancer diagnosis. I'm Dr. Nandini from Professor, Department of Pathology, JSS Medical College. A constituent of JSS Ahir, University at Mysore, Karnataka, India. Along with me, I have two of my other associates from the engineering college who have helped me with the artificial intelligence work, and my student, Dr. Prajwala Nagaraj. Before we go into the detail of our work, a brief introduction. We all know that breast cancer is the second most commonly diagnosed cancer among women population. It is the most common cancer in women. The incidence rates have been rising in traditionally low incidence Asian countries, and we can see the statistics of 2018, wherein the incidence and mortality is high in women of Asian origin. This makes us do a lot of work on it on the clinical and pathological side of these cases. We have a setup wherein breast cytology, particularly fine needle aspiration cytology, which the image is showing here, wherein we use a syringe and a needle to aspirate the breast tumor material. It is done, which is an integral part in the management of women with breast lesions in the reproductive to menopausal age group. It is used for the initial management of breast lesions and is a safe and cost-effective technique for the diagnosis of breast lesions, especially when it is correlated with clinical and imaging studies. Along with this, we have introduced another method that is called managed liquid-based cytology along with FNAC. What is it? It is designed to improve the conventional smears got by FNAC, wherein we avoid the limiting factors such as obscuring material like blood, air drying, and smearing artifacts. Advantage of this MLBC permits the use of the residual material which is available in the syringe for ancillary studies such as cell block, immunocytochemistry, and molecular studies. Why? Because these have an important role in the diagnosis of the pathology of the breast disease before we go for any surgical management. Biomarkers. These are helpful both in management and prognosis of breast malignancies. These biomarkers are regularly seen in either as nuclear, cytoplasmic, and angiogenic markers. Commonly used biomarkers like ER, PR, HER2, and Ki67 are important for diagnosis and treatment of breast malignancies. The formation of new microvessels from pre-existing vessels is necessary for tumor growth and subsequent tumor metastasis. That involves the interaction of neoplastic cells with that of neovasculature. Angiogenesis depends on endothelial cell migration, proliferation, and differentiation. The correlation between levels of angiogenesis regulated factors, clinical pathology, which we see, and the prognosis is very significant, especially in breast cancer or malignancy. So we have made an attempt to use MLBC cell block method of cytology to understand the metastatic potential of breast cancer by using, along with the regular biomarkers, angiogenic markers, that is TIC2, FLK1, and MPA1. And further, we are implementing the histopathology to study the relation of angiogenesis and tumor budding. The other latest prognostic markers, besides the modified muscle scoring, which we use for FNAC breast for diagnosis, histopathology or the tissue study uses a scoring method called as Bloom-Richardson scoring method, along with which the lymphovascular invasion of the tumor, the lymph node status, that the involvement of the tumor, along with this, there is a concept which has come in pathology, that is tumor budding. What is it? Tumor budding is a study wherein cluster of tumor cells present in the stroma or invading the edge of the stroma, They can range from 1 to 5 or 4 to 5 cell clusters. These are evaluated. There are various ways of studying this tumor budding. The study which we have done is inspired from the work done by Dr. Radhika Agrawal and et al. Coming to AI, engineering aspect of the study has gained popularity in recent times due to the advancement of fast and accurate techniques. So AI technique helps in the detection, diagnosis, and prognosis of cancers by using various imaging modalities. From the wealth of literature, it has been observed that identification of tumor budding and its clinical significance has been reported for well-studied works on IHC and IHNE images for colorectal cancers. To the best of our knowledge, we have not seen any work done for the identification of tumor budding for breast cancer using HND slide images and later on IHCs. That is why this work assumes an importance in the current scenario. Thus, this study compares the cost-effective methods like FNSE, MLBC, and cell block with IHC on MLBC and cell block, along with histopathological correlation in resource-poor settings like our hospital. IHC shows overexpression of angiogenic markers in the samples, which correlates with the stage and grade of the tumor. Tumor budding and AI will be the newer innovations which will help in improving the diagnosis and treatment of breast cancer. Thus, the objective of our study was to compare different cytological methods, that is FNAC, MLBC, and cell block, in the diagnosis of breast lesions. To study the utility of each method in the diagnosis of breast lesions, to understand the advantages and limitations of each method, and to use immunocytochemistry on MLBC and cell block to correlate cytological diagnosis with histological diagnosis wherever possible, to study the relationships of various histopathological factors with latest innovations like tumor budding and AI. Our study was conducted in the cytology section, Department of Pathology, JSS Medical College, and it includes 290 cases of breast lesions. The patients ranged from 15 to 70 years of age. It compares FNAC, cell block with HP. Immunocytochemistry was used for study the uses of these methods and the limitations. The biopsies of these cases were further evaluated for biopsy size, relationship with tumor grade, lymphovascular invasion, lymph node status, tumor budding, and their interrelation, so as to decide the prognosis and treatment modalities of these breast cancer cases. How was it done? A minimum of 3 passes, 1 for each method, was done. The material obtained were processed separately. 4 to 6 FNEC slides were made, stained with HND, PAP, and MGG. Material for cell block was put into cell block fixative, allowed to fix overnight. Deposit obtained was processed as a histopathological tissue. The material for MLBC, the study was done separately, which I will be discussing under the section of MLBC. Next. The clinical age of the patients. The age range of the patients were mainly women between the age of 15 years to 75 years. There were a small percentage of men with clinical diagnosis of gynecomastia in the age range of 30 to 40 years. Majority of the benign conditions were in the age range of 20 to 40 years, while majority of the malignancies were in the age range of 50 to 75 years of age. Now this table, the cytologically based diagnosis, was divided into different categories, that is fibroadenoma, PBD without atypia, PBD with atypia, cystosarcoma phalotes, lactating adenoma, benign breast disease, and gynecomastia, which form the major chunk of the cases, as you can see. Fibroadenoma, the benign condition, led in the most of the cases of benign condition, and they had histopathology 30 cases. While malignancy, which was 71, had cell block correlation, that is 32, and histopathology was 48. So this is telling us the percentage. The total number of benign cases were 290, accounting for 75% of the cases. The total number of malignant cases was 71 cases, accounting for 24% of the cases. The total number of benign cases with the histopathology correlation, which we are planning to speak about, were 58, accounting for 54.7% of the cases. Total number of malignant cases with histopathology correlation were 48, accounting for 45.29% of the cases. Now coming to the prognostic indicators, that is tumor budding. What is it? It's the presence of 1 to 5 cell clusters seen in the stroma close to the main tumor. There are various methods to assess the tumor grading by counting the tumor buds in HPE. As we said, the method adopted by us is the one proposed by Dr. Radhika Agrawal, wherein the maximum number of buds seen by one field by 20x are counted in a field. The tumor is divided into high-grade tumor budding if number of the buds are more than 10 in that 20x one field, and low-grade tumor buds if there are less than 10 tumor buds in that 20x field. We studied tumor budding in 40 malignant breast histopathology cases. Also, core biopsies were included following Sahalia et al., who have graded even core biopsies. And based on this, we found tumor budding, the high grade, that is more than 10 in 20x power, as 22 cases, accounting for 55% of the cases. Tumor budding, low grade, that is 18, accounting for 45% of the cases. Thus, the breast cases with high grade tumor budding were more, and that indicates that more cases had metastatic potential and they were heading for a poorer prognosis. This is the image wherein in the left side you can see the malignant breast tumor. It is in HND slide, and you can see the small cluster of tumor budding which I have pointed by the arrow from the same tumor. So this shows that this tumor has, you can see there are a good number of buds in that field, and thus it shows that this breast cancer has a high grade of tumor budding. Next. We were trying to correlate the various histopathological factors with tumor budding so that we can see what is the potential of a breast cancer going in for metastasis and have a poor prognosis. So the first factor which we have tried to correlate is tumor budding and lymphovascular invasion, and that correlation, what we can see that tumor budding without lymphovascular invasion, the high grade, it was 0. While low grade, there were some 13 cases that account to 36.2% of the cases. But tumor budding with LVI in high grade was 18, accounting to 50% of our cases, and low grade was only 5. Thus, there's a strong correlation between high grade tumor budding and LVI. Coming to tumor budding and lymph node metastasis correlation. The high-grade tumor budding with lymph node metastasis was seen in 9, that is 31.3% cases. Without metastasis was seen in 4, that is just 13.79%. Low-grade tumor budding with lymph node metastasis was seen only in 2 cases, that is 6%. Without lymph node metastasis was seen in 14. Thus, the high-grade tumor budding has a strong relationship with lymph node metastasis, making it a factor for an important prognosis factor. At the same time, low-grade tumor budding is seen in good number of cases which are not associated with lymph node metastasis. So this is an indicator of good prognosis. Only we had certain limitations. There's that cases where there was core biopsies and lumpectomies done, we could not do this correlation. Now coming to an important aspect, which latest a lot of people are working on this, is tumor budding and immune markers. There's a good association between immunomarkers like estrogen and antigenic markers, which help to indicate the metastatic potential of tumors. The ISCs were studied on 32 cases, of which estrogen positive in high-grade tumor budding was noted in 11, that is 34.37% cases. In low-grade tumor budding was noted only in 9, that is 28% of cases. While estrogen negative in high-grade tumor budding was noted in 5, and low-grade tumor budding was noted in 7, that accounts for 21% of the cases. What does this indicate? That there's a strong association between tumor, that is between estrogen positive marker with high-grade tumor budding, as estrogen is known to play a role in epithelial mesenchymal transition and stemness. This helps in the metastasis of the tumor cells, and this factor is a strong correlation with estrogen because it helps in the transition of epithelial cells to mesenchymal cells. This is similar to other studies as presented by Sally and Cadis. There are also tumors which we saw were estrogen negative and associated with low-grade tumor budding, which indirectly substantiates that estrogen is an important factor for metastasis. You can see an image. The left side, you're seeing the malignant tumor, lot of lymphocytes around it. And the right side, as the arrow is showing, the dark brown nuclear staining by ER positive malignant breast tumor of the same case. Next slide. Then we are trying to highlight the tumor budding, as you can see the arrow showing. The major part of the tumor is shown below, while at a certain distance, you can see the tumor budding, which is ER positive. The right side image shows the tumor budding, the ER positive, lot of them here, and it is very clearly made out in this image. So ER positive, when we use it, the tumor budding is more clear. So as we go ahead, besides the regular markers, antigenic markers which we have used are MTA1, TIC2, FLK1. These markers are known to be associated with high metastatic potential of breast tumor. And we found that they were strongly positive in sample cases which we have tested. Thus, the association with angiogenesis and high-grade tumor budding is noted wherever all the cases with high-grade tumor budding showed strong positivity for angiogenic markers. Thus, angiogenic markers and high-grade tumor budding, when highlighted, indicate a high chance of metastasis of the breast cancer. These help in treatment modalities wherein anti-angiogenic drugs will have to be considered in management of the breast cancer cases. So this is, I'm trying to show in cytology what we tried to do in our setup. In the left upper hand corner is FNAC, that is a fibroadenoma breast, Pap stain. This is, the right side is MLBC, fibroadenoma. The left side, the lower left side is a cell block FA breast. And all these are by regular stain. And the right side confirmation by histopathology. Now with the markers. The cell block with the markers was studied. You can see that TIC2 is negative. FLK1 in breast, benign breast is negative. MTA1 in benign breast is negative. And the same thing in MLBC also, it is negative. Now when we'll see it in CA breast, how does it look? So this is the left upper hand, you can see is FNAC CA breast. Right side is MLBC CA breast. The cell block of CA breast and the correlating histopathology of the CA breast. And you can see the strong positivity of these markers by the dark brown color, which shows, highlights the blood vessels. So TIC2 CA breast is positive, FLK1 is positive, MTA1 is positive, and also in MLBC, we can see that this angiogenic markers are made it positive. We also further studied it in the histopathology tissue. I'm giving an example of one case. So the left side, you're seeing the malignant breast tumor with a tumor bud. The right side, the same case, ER is strong positive. The PR on the left side, ER, PR, HER2. So PR is showing positivity. It is not as strong as the ER. The HER2, which is a third marker, is negative. Left side, Ki67, which is a proliferation marker, is strongly positive. Now coming to the angiogenic markers, FLK1 is positive. MTA1 is positive. Then TIC2 is positive, and you can see the positivity in FLK1 also. So finally, this case was FNAC, it was diagnosed as duct carcinoma. The LBC could not be done and cell block did not show a deposit. Histopathology biopsy was studied, wherein it showed lymphovascular invasion. Lymph nodes were reactive. Then we did the scoring, wherein it was 6, that is grade 2. And size of a tumor was 5 into 4 into 1 centimeters, and the staging was T4 without nodal metastasis. Now coming to the IHC of that. The ER was positive, PR was positive, HER2 was negative, Ki67 was positive, and all the 3 angiogenic markers were positive, while the MTA1 being the strongly positive marker. So coming to tumor budding with tumor size. We took large and small size tumor. Large tumor size was taken where it was equal to or more than 3 centimeters. Small tumor size were taken when they were less than 3 centimeters. High-grade tumor budding was large tumor size was seen in 17 cases, accounting for 44%, with small tumor size for 5 cases, accounting for 13% of the cases. Now, low-grade tumor budding was seen in large tumor only in 4 cases, with small tumors we were seeing in 12 cases, accounting for 31.5%. Thus, tumor budding has a direct relationship with tumor size. High-grade tumor budding has a closely related to large tumor size. Similarly, with low-grade tumor budding is associated with small tumor size. The next histopathologic correlation is the tumor budding with histopathology grading, which is called as modified Bloom-Richardson scoring, classifying the tumor grades into grade 1, 2, and 3. So once we saw that, we found that high-grade tumor budding, grade 1, there was only 1 case. Grade 2 was a maximum with 16 cases, and grade 3, there were 11 cases. Low-grade tumor budding was in grade 1 as 1. Again, grade 2 in 11 cases, accounting for 26% of the cases, while grade 3, there were only 2. Thus, there's a strong correlation of high-grade tumor budding with grade 2 and grade 3 of the Bloom-Richardson scoring. There are few cases in score 6, grade 2 in low-grade tumor budding. I think the automation may help us to clarify them better. Coming to the techniques which I was telling, that is cell block and breast cancer. The cell blocks is being extensively used in all cancer centers in our setup and even in Bangalore. Why? Because it helps us to, much before the surgery is done, to take the tissue and do IHCs. In our setup, in our study, we did cell block for 44 cases, which with majority of them clinically diagnosed as malignancy. In that, the benign cases were 8, while negative for benign were 3. Malignant were the maximum, that is 32 cases, accounting to 72.72%, and negative was only 1. What is cell block? It's an ancillary technique which can be used in manual liquid-based cytology, and it helps in confirming the diagnosis of FNAC. It can also be done in cases of breast FNAC, wherein the material in the needle hub is processed, and it is processed for cell block, like in histopathology tissue, especially in cases where there is clinical suspicion of malignancy. This helps also to increase the diagnosis in hemorrhagic aspirates in malignant breast and facilitates and use of it in IHC studies. Last but not the least is manual liquid-based cytology and breast cancer. Manual liquid-based cytology is a method by which monolayer of cells are formed on the slide with removal of all the obscuring factors like blood and inflammatory cells. It helps in improving the diagnosis of breast cancer. IHC studies can be done on it directly. We did this separately along with cell block and HPE in a separate study of 60 FNAC cases, which we got them from the surgical OPD to the cytology department. This table shows the FNACs which we have done. MLBC, almost all of them, especially fibroadenoma and malignancies, and they all were confirmed almost by HPE. This is the image you can see by FNAC, the CA breast, the MLBC, CA breast, and MLBC and CA breast, which is ER positive. Now coming to AI, this was done by my colleagues from the engineering college of our institution, SJC, that is Anand Murthy sir and Shivmurthy sir. We are in the initial budding stages of this tumor bud detection by artificial intelligence. So this methodology, which we are planning to use in the future, is one of the state-of-the-art method in tissue diagnosis. This has a deep learning algorithm, which has emerged as a promising method for tumor detection. We are presenting a small set of cases. We gave it to them to analyze the breast cancer cases. So a brief mention of what it is they have done. Deep learning model is a conventional neural network, a well-known deep learning architect method in AI. It is used mainly in medical image analysis, histopathological image analysis, MRI, CT, and X-ray image analysis, and endoscopic procedures. We supplied to them a data set wherein they studied 40 non-tumor bud images of breast carcinoma, 62 tumor bud images of the breast carcinoma, and they came with an observation. That is, learning accuracy of the model for known sample, they gave us as 63%, detection accuracy for unknown sample as 63%. And these are the results, promising results they gave us. The quantitative measures, the accuracy was 63.6%, precision was 63.6%, the recall was 100, FI1 score was 0.78. Thus, they say that learning and detection accuracy has remained the same. There is number of samples. Obviously, we had just started with this concept. The data from both the class of similar morphology and the recall, as you see, shows the efficiency of the model in detection of tumor buds. The model is able to detect tumor budding with 100% accuracy. Precision indicates probability of detection of tumor bud cases. This model projected it as 63% of precision. Now, to come to a conclusion, breast cancer is most common cancer in women, with its increasing incidence in Asian women because of their lifestyle changes. There are various early, cost-effective methods of breast cancer detection, which are very useful in tertiary care center like ours, which is a charitable hospital. FNAC, MLBC, cell block are the methods which are painless and give the first diagnosis for management of breast lesions. Along with them, there are new innovations which help to decide the metastatic potential of malignant tumors. These affect the prognosis and treatment modalities of breast cancer. In that, tumor budding is one of the latest methods to assess the metastatic potential of a tumor. Immunomarkers like estrogen and androgenic markers like MTA, TIC2, FLK1, which play an important role in prognosis and drug therapy, are the latest innovations to be worked on in a large scale. Artificial intelligence is slowly playing an important role in increasing the diagnostic accuracy of malignant breast lesions. Thus, various non-invasive, invasive methods are being introduced in diagnosis, prognosis, and management of breast cancer. They're all helping in reducing the mortality and morbidity of breast cancer women worldwide. These are my references. I would like to thank all my staff, postgraduates, and technicians of the Department of Pathology, JSS, Mysore, Karnataka. I thank Sonali for her statistical assistance. I thank all for a patient hearing. Hope we have a better understanding, better learning, more advanced, easy, cost-effective methods for detection, early detection, and treatment of breast cancer in Asian women.